Welcome to another episode of the AUA University Podcast. I'm Dr. Mark Gonzalgo, Professor of Urology at the University of Miami and Chair of the AUA Office of Education. Today's episode focuses on the updated AUA guideline for clinically localized prostate cancer, an area that continues to evolve rapidly as advances in imaging, biomarkers, focal therapy, radiation, strategies, and artificial intelligence reshape how we diagnose, stage, and manage patients. I'm very pleased to welcome Dr. James Eastham, Chief of Urology at Memorial Sloan Kettering Cancer Center and one of the leading voices in prostate cancer management and guideline development. James, welcome. It's truly a pleasure to have you with us today.
Thank you, Mark. It's a pleasure to join you and to work with you on the AUA guidelines.
Before we get into specifics, can you give our listeners kind of the big picture overview of what makes this latest guideline update particularly important?
Well, I think, as you mentioned, the field of urology and prostate cancer in particular is changing rapidly, and the guidelines need to be updated periodically to reflect those changes. Certainly in the realm of imaging, shared decision making, updates on active surveillance, and several other pathways that we follow in prostate cancer, all have changed. And the guidelines, which were written about 5 years ago, needed a bit of updating to make them more current.
James, before diving into the clinical recommendations themselves, I think it's important for listeners to understand how these guideline statements are actually developed. Can you walk us through that process?
Yes, and I think that leads to some of the criticism that sometimes comes from folks reading the guidelines is that the methodology that's used is quite strict, and we can't just have expert opinion that guides everything. So initially, the panel is convened, and the panel generates a series of statements that we think are appropriate for the guideline. Those statements are then given to a methodologist. We use methodology group from Oregon State, and they do a systematic literature review using the PICOTS, PICOTS methodology to identify manuscripts that are appropriate for each of the statements. And then the people that are part of the guidelines, the guideline members, review all of those manuscripts to see what are appropriate, what literature is appropriate for a given statement. And there have to be certain levels of evidence which are reached to be included in the guidelines. So, and we'll probably get to this in the future during this podcast, you know, many people do focal therapy, including at our center. We do a lot of focal therapy. And there have been criticisms that the guidelines just don't make a strong enough statement. And that's based on the methodology. There's not a lot of good literature, meaning prospective randomized trials in the focal arena that reach the level of evidence that's appropriate for a guideline statement. And again, it doesn't mean focal therapy can't be used. It doesn't mean it's inappropriate to use, but the guidelines just don't fully support that treatment strategy as reaching the level of radical prostatectomy or radiation therapy. So there are some nuances. It takes up about 5 pages of the first part of the guideline statements of how the methodology is actually carried out, but there are very strict criteria that we follow.
Right. You mentioned that focal therapy as one particular area where evidence might remain limited or is still evolving. I guess for our listeners, how does the committee or our guidelines handle those areas where such evidence remains limited?
Well, the statements are basically hedges. Um, from I think most of us would agree that focal therapy should not replace active surveillance in the appropriately selected patient. So if a patient is an active surveillance candidate, they should not be treated. Focal therapy basically is not used in a single speck of Gleason score 6. At the other end of the spectrum, patients that are at very high risk, grade group 4 disease, probably shouldn't be treated with focal therapy either, because many of those patients haven't even been studied as part of single institutional pathways. So, if there is a sweet spot for focal therapy, it's probably in the favorable or unfavorable intermediate risk group. And the statements say that this is not a proven pathway. It does not reach a standard of care, but if those patients are going to be treated, they should be followed appropriately so that we can generate data so that hopefully in the future we'll have better evidence for focal therapy to get a stronger statement in the guidelines.
Great. So I think, for our listeners, the guidelines is not just a list of recommendations. I think in many ways it's a framework for evidence-based shared decision making.
Yeah, I would agree with that completely. Guidelines are just that. They're not, you have to do it this way. There are very few statements that say this is the only path one can use. It's basically there are a variety of paths, and in the discussion of options with the patient, one can come to a consensus about what works best for that particular person that's in front of you that you're consulting with.
And we'll come back again in a few minutes to the subject of focal therapy, because again, that appears to have some continued and evolving interest. But moving forward to once a patient has been diagnosed with localized prostate cancer, James, one of the biggest areas of evolution has been staging evaluation, right? How
Correct.
has the guideline changed in terms of imaging and risk assessment for this group of patients?
Yeah, I mean, one of the changes was using PSMA imaging as a first line test. In the last version of the guidelines, the one that was published several years ago now, we still used cross-sectional imaging as the standard, either MRI usually or CT scan plus a bone scan, and then PSMA imaging was used in selected patients. We now have brought PSMA imaging um, into a first-line imaging tool to stage patients. So there's more evidence available. And so that has been prioritized in the updated version of the guidelines. Um, in addition, most patients are recommended to have an MRI prior to biopsy. The blind biopsy, systematic biopsy, solely based on routine ultrasound is not what most of us do in practice. So doing an MRI prior to the initial biopsy is a recommendation that's pointed out in the new version of the guidelines. So the imaging has been updated.
Great. And one of the other areas I think that many folks begin to incorporate into that initial staging evaluation are biomarkers. What are your thoughts on this? In terms of what types of biomarkers are used today, and where might biomarkers truly add value?
Great question. I think it's still evolving. I think the area that the guideline emphasizes is that not everyone needs a biomarker, that much of our clinical decision making can actually be made with readily available data that we have: PSA, imaging studies, biopsy information. Um, Not everyone with a single core of grade group 1 needs a genetic test. I think biomarkers are useful in those patients that are having a difficult time deciding between treatments, and that's where the genomic testers, Decipher, Prolaris, etc., are useful. Artera AI is a newer study that can be utilized to help decide whether active surveillance or treatment, or perhaps more intense active surveillance, may be warranted. I think where the biomarkers have proven most useful is in the selection of patients whether they receive hormonal therapy or not with radiation, duration of hormonal therapy, or intensification of hormonal therapy. I think that's the area where they're primarily most useful. I think the standard patient that comes in with low risk prostate cancer probably doesn't need a biomarker to confirm that he's an active surveillance candidate. Um, so I use biomarkers judiciously. I do not use them on everyone. I tend to use them on the patients that are sort of can go one way or the other just to get a little bit more information. And I don't let a biomarker um, overweigh or be given more weight than the other pieces of data that we have. If everything lines up on the favorable side of the ledger and someone has an intermediate biomarker, why should that now be the be all in terms of making a recommendation for treatment? And I think that's what the guideline says. It's basically says that biomarkers don't need to be used in everyone. And in those patients in whom they are used, they should be part of the evidence in shared decision making.
That's great, great words of advice, and thank you for that. It's also important to keep in mind, I think, for listeners and clinicians out there, that as we continue to have an increasing number of imaging studies or biomarkers, the challenge really at some point is really no longer simply just obtaining more data. It's knowing which data meaningfully change management.
Completely agree. I very frequently tell the trainees, you get a test if it will change what you're going to do. You don't need to get, there's lots of tests available, and in a particular setting, they may be very useful, but they're not necessarily useful in every single setting. So you use a test if it's going to help you and the patient make a meaningful decision. Otherwise, it's just a test. And you might as well save the money on getting, I don't think there should ever be a routine test. All testing should be well thought out as to, well, what am I going to do with the result? Um, and if the result's not going to change management, don't get the test.
Right. Absolutely. So let's return to an area that continues to generate a tremendous amount of interest, from both patients and clinicians, and that's focal or ablative therapy.
Mhm.
How does the updated guidelines approach this particular topic?
So we recognize that focal therapy is being utilized. Most of the technologies are approved for tissue ablation. They don't have a specific cancer indication. And we mention in the guidelines that if patients are candidates for active surveillance, that they are managed with active surveillance, that focal therapy is not necessarily useful in that particular situation. The specific statement says that focal therapy in patients with favorable or unfavorable intermediate risk should have discussion that this is not yet to the level of a standard of care treatment. It should be used at least as part of a registry type program so that we can get that added information in terms of generating the information and longer term outcomes. I think that's what's lacking in most of the focal therapy um, manuscripts is that we know it's safe. Certainly, that's the appeal of focal therapy is that the quality of life issues are far less significant than with whole gland treatments like surgery or radiation therapy. We do destroy tissue. I think there's certainly imaging and biopsy evidence that focal therapy does that. What we don't know are the long term outcomes, either with in field or more importantly, out of field recurrences, and what that means for the individual patient down the road. And I think that's the information that is lacking. And focal therapy is often described as, well, we just kick the can down the road a little bit, making it seem as if that if you kick the can down the road, that at that next point where treatment is needed, that you haven't lost anything. And we don't know that yet. Um, and I think that's the data, the type of data that needs to be gathered so that we can be more comfortable recommending this as a guideline statement, meaning it reaches the level of all of the parameters that are in the guidelines to be included as not a option that should be considered research, but a potential standard of care option, that's shoulder to shoulder with the other things that we do.
Absolutely, and I think these are the types of details that are important when considering potentially using this type of treatment for our patients. Because patients often perceive focal therapy as less invasive, but they may not appreciate either the surveillance intensity that might follow depending on the
Right.
protocol, or as you said, the long-term implications and the potential implications if additional therapy, including salvage treatment, might be needed down the road.
Right. Yeah, and the specific statement is basically that whole gland and focal ablation remain investigational, and I think that the longer term data, and I'm not talking about overall survival data, we're not going to get that. I mean, I don't think that's required, but I think the implications, at least within 5 to 10 years, what are the true retreatment rates? What are the reclassification rates? What are the patients that go on to need hormonal therapy, more intensive treatments, develop metastatic disease? I mean, I think those are the types of endpoints. We don't need, prostate cancer survival endpoints, perhaps not even metastatic endpoints, but certainly what's the overall burden of treatment? Um, and we just don't have good quality data as of yet.
Right. Another major area of evolution, and you touched upon this briefly earlier, is how we integrate ADT with
Mhm.
radiation therapy, particularly as biomarkers and imaging become more sophisticated. What are key updates clinicians should understand?
Yeah, it's a great question. And the biomarkers, whether it's Decipher or Artera AI, those are the two most commonly used to help define the role of ADT with radiation therapy. They're used in a couple of different settings. In the 4+3 equals 7 grade group 3 patients, whether or not hormonal therapy will provide a benefit is one of the areas where the biomarkers are useful. And I think that that's an area where I think biomarkers, help generate information. For patients with very high risk prostate cancer, whether or not treatment intensification, meaning not just ADT alone, but ADT with one of the ARSIs added, might be beneficial. Those are the areas where biomarkers are helping select patients to either intensify or de-intensify hormonal therapy with when radiation therapy is utilized.
I was going to ask that question. I think you alluded to it. A lot of the focus sometimes is on treatment intensification, but de-escalation is also potentially becoming more important, and that's where some of these biomarkers may influence treatment.
Correct. And, whether or not in the high risk population that opt for surgery, whether or not there will be a role for hormonal therapy, androgen deprivation therapy, there's clinical trials that are waiting to report on that. And then it will be, well, how do we select patients? It's rarely everybody needs this or everybody doesn't need this. And I think that's where some of these biomarkers will help guide us in terms of certainly right now in radiation therapy, they're essentially standard of care to check a biomarker. In the upfront setting, does the patient benefit or not benefit from addition of ADT to radiation therapy? How long should the ADT be given? Should it be ADT plus something like abiraterone? In the salvage setting, will the addition of hormonal therapy be beneficial. So I think that that's an area of advancement. The guidelines address that in much more detail than we can on this podcast, but certainly that's an updated area and will continue to evolve.
Right. James, maybe looking ahead a bit, what additional developments do you think are most likely to reshape the next version of this guideline?
I think we'll get better imaging and more information on imaging. I mean, micro ultrasound has been compared to MRI, and whether or not micro ultrasound will, or how micro ultrasound, not whether it will, it's already being used, but how that will complement um, uh, MRI findings. Can intraoperative imaging be utilized? Whether it is something like ultrasound imaging, looking at Dopplers and things like that for blood flow around nerve tissues and identifying structures, image guided surgery where we have, PSMA that glows and can show areas of abnormality that the naked eye just doesn't appreciate. There are nerve imaging protocols that are being looked at. So I think image guided surgery will certainly be something that we look at in the future. I think the other area of advancement that we're all excited about is artificial intelligence and how that will allow us to integrate things. And we already have that. I've mentioned our Terra AI a couple of times. The naked eye just doesn't see things that a computer can. And while it is a bit of a black box and we'd like to know what's in the black box, what are they actually seeing? Um, Whatever it is, it seems to be predictive. So I think we'll get more artificial AI platforms that help us better counsel patients how to, what might be best for them. Again, treatment intensification, de-intensification, these pathology features, independent of Gleason score, can predict a better or worse outcome. I think those types of platforms are definitely going to be or are being developed and and will be utilized in the future. Certainly, I think we'll get better targeted therapy. We have the lutetium-based platforms with PSMA. I think there'll be other types of smart bombs that are be able to be delivered in the neuroendocrine space. I think we're finding specific neuroendocrine targets that might be utilized to deliver primarily radiation therapy to neuroendocrine based tumors. So I think it's an exciting time to be in um, in the prostate world, both at the very low end risk of the spectrum, but also in the higher end risk of the spectrum. I think that urologists will continue to play a critical role in managing these patients. Um, for patients that are managed with active surveillance, do we really need to do biopsies as a matter of routine, or will we find markers that we can use? I mean, there's the urine markers, the My Prostate score. I was at the AUA, I think this year it was reported that it can better select patients who may not benefit from serial biopsies. More of those types of markers will come out. So I think there's a variety of areas, markers, imaging, targeted therapies, intraoperative imaging that will continue to improve our abilities to better take care of our patients.
Very well said. Now, James, as we wrap up, what do you hope practicing urologists, residents, and fellows take away from this updated guideline?
I think that the field is changing. I think that's one of the areas that guidelines have to continue to be evaluated because the methodology is so intense, it takes time. When a guideline is first envisioned, it's not until 2 years until the actual publication comes out. So I'm hoping that people will contribute. we're always looking for people to be on the guidelines. It does require a bit of time, but it's certainly a very educational and great process. I think anyone that's been on a guidelines appreciates the depth and breadth of what a guideline involves. Um, I think guidelines always point out that there's more knowledge to be attained. Every guideline has a future directions, and I think as we've touched on just very generally, there are a number of areas where we need more information. Biomarkers, imaging, things that add to the routine things that we've used for the last 20 or 30 or 40 years to better care for our patients. So I think there's lots about guidelines. They are just guidelines. They're not, the 10 commandments, so to speak, in terms of you have to do it this way. Not that the 10 commandments were ever followed very strictly, but guidelines are always open for improvement. And, that's where we need the research and the investigation. So hopefully guidelines will not only guide patient management, but also guide researchers into important questions that should be answered.
Well, Dr. Eastham, thank you for an outstanding discussion. This updated guideline highlights just how rapidly localized prostate cancer management continues to evolve, from imaging and biomarkers to treatment selection and future AI-driven decision support. I think one of the major themes from today's conversation is that modern prostate cancer care is becoming increasingly personalized. I think our listeners will especially appreciate the practical perspective you've provided on integrating these rapidly emerging technologies into real-world clinical decision-making. To our audience, thank you for joining us today. For more educational resources, including AUA guidelines, CME activities, surgical videos, and additional podcasts, please visit auanet.org/university. I'm Dr. Mark Gonzalgo, and we look forward to bringing you another episode of the AUA University podcast as we continue advancing excellence in urologic education and patient care.